Good evening, everybody, and thank you so much for logging in tonight. I'm Katie Pryor, the Manager of the Education Programs here at the Western New South Wales PHN. Tonight, I'm really pleased to introduce you to Liz Robinson, who's a new member of our team. She's the Education Coordinator based out of Bathurst, and I'm going to pass over to Liz now to get this webinar started.
Thanks, Katie. Welcome everyone to our webinar tonight. I'd just like to start with an acknowledgement of country. The Western New South Wales Primary Health Network acknowledges that we work on the traditional lands of many Aboriginal clans, tribes and nations. I'd like to pay respect to elders past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to the life of the communities in our region. This webinar is being recorded and will be made available for viewing on the Western New South Wales PHN website. At the completion of the webinar, a short survey will pop up on your screen, so please take a moment to complete that survey for us. If you can't see the toolbar, click on the small orange arrow, usually at the top left-hand side of your screen, and then the panel below should look like this. Every participant is automatically in listen-only mode. This is to optimise sound quality for all participants. If you have questions or comments, please use the chat questions box and our presenters will respond, but we'll keep the responses to the questions until the end of the presentations in the interest of managing our time tonight. Click on the small triangle to open the dialogue box and type your questions or comments in down there. A couple of biographies of our presenters tonight. Our first presenter is Dr. Phillip Butler, who was born in Dubbo and grew up in Wagga Wagga. He studied medicine at the University of Sydney, including 1 year spent at the School of Rural Health in Dubbo. After working as a junior medical officer at Concord Hospital, he completed training in geriatric medicine at Concord Hospital, Royal Prince Alfred Hospital, and the Hunter New England LHD. Phil moved to Orange with his family in early 2018 and was appointed as a staff specialist physician and geriatrician at Orange Health Service in 2019. Dr. Catriona Ireland graduated from Sydney University in 1993 and completed her fellowship training in geriatric medicine in 2001. She lived in Orange and provided outpatient geriatric and memory clinic services to the area from 2000 to 2012, as well as supporting inpatient services for the management of delirium and nutrition in acute hospital. While returning to Sydney in 2012, she continues to visit regularly to support the outpatient clinic. Since 2016, she's been a clinician and research affiliate at the Brain and Mind Centre, Sydney University, where she's involved at the long-running Healthy Brain Ageing Research Clinic. She works closely with the Wilcox Sleep Institute and holds a fellowship with the Centre of Research Excellence to optimise sleep in brain ageing and neurodegeneration. She's soon to join the Macquarie University team working on the Australian arm of an international effort to establish the evidence base for multi-component interventions to reduce risk of dementia. Any templates or links referred to in this presentation will be mailed to attendees after the webinar.
Good evening, everyone. It's Phil Butler here. Thanks for taking time on a cold May evening to listen to our presentations. I'll be speaking first, followed by Catriona. I've got a special interest in what's often labelled polypharmacy. I can't profess to be an expert, but it's a field in which evidence is often hard to come by, and some could argue that there are no experts. I'll be giving my view on the term polypharmacy and then moving on to what I think is a more useful term, the potentially inappropriate medications in the elderly. If we have enough time, I will touch on deprescribing as well, but we may run out of time for that. So I quite liked this statement by one of the world experts in polypharmacy, that as older patients move through time, often from doctor to doctor, they're at increasing risk of accumulating layer upon layer of drug therapy as a reef accumulates layer upon layer of coral. And I guess that reflects the general phenomenon that it's easier to prescribe things than it is to get rid of medications off a medication list. I'll give a few disclaimers before I go any further. I'm really conscious that many of the medications I'll be talking about tonight are prescribed for symptoms that drive people nuts and that aren't readily managed. Things like insomnia, nocturia, pain, and that it can be really irritating when those medications are in a pen stroke crossed off during an acute admission. Ideally, deprescribing decisions are made in consultation with patients and doctors who know these patients best. Another disclaimer is that I've myself prescribed many of these medications at different times, and what I'm hoping to achieve is a bit of perspective on some of the harms that can come of these medications, which I see a lot of because of the biased group of patients I look after. So I'll start with what I think is an illustrative case study of an 82-year-old woman who I met last year, who frequently presents to hospital after falls. Her background includes ischemic heart disease, hypertension, a pacemaker, spinal canal stenosis, hypothyroidism, atrial fibrillation, type 2 diabetes mellitus. So with that list of medications, you'd anticipate if this patient was receiving guideline recommended medications that she'd be on a lot of medications, but you probably wouldn't expect that she'd be on 26, which I think is the most I've seen in the last couple of years at least. And looking through that list, you will see many medications that are directly linked to her nominal background list and many that aren't. And I guess if I have time to get to deprescribing, I'll be talking about picking the low-hanging fruit, of which there are several on that list. So this idea of polypharmacy, which is generally defined as a high number of medications rather than any particular type of medications, came about because there are general concerns about medications in older people. The risks of many medications are often increased in terms of how likely they are to occur, how severe those risks are, and the functional implications especially. And the benefits may be variable. Sometimes they're actually more beneficial in older people, sometimes less, or more commonly not known at all. The reason that we're often in the dark in this regard is that historically older people have been excluded from randomized controlled trials. So the net benefit of a medication in an older person may be really unclear. So just to illustrate how older people have historically been systematically excluded from high quality practice changing trials. This is a bit old now, but in 2011, a review of heart failure trials showed that close to 50% of big trials had poorly justified exclusion criteria that really limited the inclusion of older people. And this can be done through having an upper age limit, but there are other exclusion criteria that are more insidious and lead to exclusion of older people, like excluding people with reduced life expectancy, which you'd think would be the norm in a good heart failure trial, excluding people with certain comorbidities, either specific ones or a generic number of comorbidities, excluding people with cognitive impairment, physical disability, and drug use, for example, polypharmacy itself. So, in fact, most inpatients in this 2003 trial, most inpatients admitted with heart failure wouldn't actually have made it into some landmark trials that have led to practice changing prescribing of ACE inhibitors, beta blockers and spironolactone, people with heart failure with reduced ejection fraction. So if you look at the SOLVED trial, which led to widespread acceptance of an ACE inhibitor as giving mortality benefit and reduced hospitalizations in people with heart failure, only 18% of real-world patients admitted to hospital with heart failure would have actually made it into that trial. And similarly, the MERIT heart failure trial and the RAILS trial, which looked at metoprolol and spironolactone respectively, had really low rates of real-world patients. So this paucity of evidence regarding medications in older people contributes, I guess, to suspicion that polypharmacy might cause harm. Polypharmacy is certainly really common. This is some data that's 8 years old now from the MJA. It's Australian data, which shows that by the time that people get over 75, actually polypharmacy, if it's defined as more than 5 medications, is the norm. So it's more than 50% of people over 75 take 5 or more medications, and it's an unusual older patient who doesn't have polypharmacy as defined by 5 or more medications. So why might the number of medications be harmful? Well, there's increased likelihood that some of them will be inappropriate. There's an increased risk of interactions either between drugs on the normal drug list, between drugs and diseases, or between drugs and geriatric syndromes. And by that I mean things like falls, delirium, frailty, dementia. There's also an increased risk of prescribing cascade, and by that I mean prescribing medications to treat the symptoms of other medications that perhaps the patient doesn't need. A good example would be, say, an antipsychotic that's been used to management of wandering in a nursing home in the absence of psychotic symptoms, and then Matapar used to treat the Parkinsonian features that result from that. That's something I see every now and then. There's also increased risk of medication errors made by patients, especially in the setting of cognitive impairment or difficulty physically opening Webster packs. I know on home visits, I always get patients to actually show me how they get their medications out of the kitchen cupboard and show me how they pull them out. And the norm really is difficulty doing that. And Webster packs certainly don't solve that problem because you can end up with tablets all over the carpet. Increased monetary cost is a problem for some people, but not all, depending on how they pay for their medications. That's all very well, but does polypharmacy actually cause harm? And it's actually quite hard to work out. Studies in this field are observational in nature by necessity. You can't have a randomized controlled trial where you randomize half of the cohort to 5 medications and the other half of the cohort to 10. You just can't do that. So, and because polypharmacy is often a consequence of having lots of diagnoses, lots of medical problems, you end up being plagued by confounding factors. These are the results of some of these observational studies. They're pretty variable. So many studies which have looked at links between number of medications and falls have found a direct link, anywhere between 6 and 7% for each extra medication. It was actually the 2012 Gnidich trial in Sydney that was really the source of 5 or more medications being labelled as polypharmacy. There's also been a lot of trials that have showed a link between polypharmacy and hospitalization or mortality. These were trials that tried really hard to adjust for chronic disease or multimorbidity. The problem for these studies is, again, that it's really hard to measure comorbidity, and we all know of patients who only had 2 diagnoses but look really frail or look older than their stated years. And similarly, we all know patients who have 15 medical problems on their list of diagnoses but actually look remarkably well. So this study from the 1990s really illustrates that nicely, I think. They looked at 100,000 patients and looked at the relationship between 20 common drug classes and mortality. And they tried really hard to adjust for all of the things that could affect mortality, including the Charlson Comorbidity Index, which is commonly used in trials to adjust for comorbidity. And what that showed was something that clearly doesn't make any sense, that some medications like anti-glaucoma drugs and anti-anxiety drugs appear to have a protective effect when it comes to mortality. That's clearly ludicrous, and what that demonstrates is that there's a lot of unmeasured comorbidity that's at play here. So in a nutshell, I take the results of observational studies on polypharmacy with a grain of salt, which leads me to what I guess my idea is of a more useful concept than polypharmacy is potentially inappropriate medications. And I think it's good clinical practice to look for potentially inappropriate medications in medication lists of any length. It could be on one medication or 20. So my next case, I think, illustrates that point nicely. A few years ago, I met an 87-year-old man who was living independently at home alone. He wasn't cognitively impaired. He was a volunteer. He ran a community cinema club, and he'd been admitted to hospital after a fall. The ward JMO looking after this man chased up his usual medication list and got a list from his local medical centre that only listed one medication, and that was oxybutynin. So he was charted for oxybutynin 5 milligrams TDS, and the JMO charted that because he was also looking after a young woman with multiple sclerosis who was on oxybutynin at that dose and frequency. Within a day, this man had a profound hypoactive delirium, and that persisted for several days until the medication error was identified. And when that medication was stopped, he recovered a little bit, but not a lot, and he required nursing home placement. Because I raised that case as an example of one single medication rather than polypharmacy that's led to profound harm. There are lists of potentially inappropriate medications that have been compiled via a somewhat systematic process. The most widely known one is called Beers criteria. It's a really long document, and so not terribly useful for day-to-day use. It includes lists of potentially inappropriate medications in older people in general, in older people with certain diseases or syndromes, and a separate section for drugs needing dose adjustment in the setting of renal impairment, as well as drug-drug interactions that are of particular relevance to older people. It's pages and pages long, and so I've tried to only discuss the medications that I see most commonly in my practice as being a problem. So the big ones that I see problems with are often anticholinergic drugs. These are medications with highly anticholinergic properties that are best avoided in elderly people in general. And I think a take-home message would be to, when prescribing a new medication to an older person, think, is this medication an anticholinergic medication, and is it worth it? So the risks of anticholinergic drugs are really considerable, and they include delirium, which can be precipitated by the medication itself, and a long-term increased risk of dementia. Urinary retention is a common problem. Dry mouth can be a problem, especially in people who are meant to be on a fluid restriction, because it can lead to poor compliance with that. Constipation can be a big problem. In practice, I haven't come across reduced sweating lead to hypothermia as a problem, but it's a theoretical risk. Orthostatic hypertension, a common problem, and one we see in patients who've come in with falls, not uncommonly. So somewhat alarmingly, there's pretty strong evidence that some, but not all, anticholinergic drugs are associated with increased risk of dementia. And really, I think that should be included in the discussion of risks and benefits when prescribing strongly anticholinergic medications. And by strongly anticholinergic medications, the main ones I'm talking about are oxybutynin and certain antidepressants, amitriptyline being the one that's most commonly prescribed. Prolonged exposure to anticholinergic drugs is associated with cognitive decline and incident dementia in multiple studies. That's been reproduced. In the past, there was some uncertainty about the possibility of reverse causality, and by that I mean, say somebody sees their doctor about urinary symptoms, is prescribed oxybutynin, and then develops dementia, and the idea was that perhaps those urinary symptoms were an early sign of the dementia to come. That really doesn't appear to be the case, because There's been some recent high quality case control studies that went back 20 years and found a pretty consistent association between highly anticholinergic medications and incident dementia. So the odds ratio for dementia with use of amitriptyline 15 to 20 years earlier is 1.19, which is, I think, pretty alarming. However, if you calculate the number needed to harm from that odds ratio, it's actually about 50. And so there are many older people that probably get away without getting dementia despite being on a drug like amitriptyline. Several times a year, actually it's probably once a month, I would see a patient who's clearly had dementia precipitated by oxybutynin or amitriptyline. They went from being only mildly cognitive impaired or just normal to having established a dementia clearly because of the commencement of oxybutynin or amitriptyline. So what are the strongly anticholinergic antidepressants? Amitriptyline is the one I see the most of, but clomipramine, nortriptyline, imipramine, and doxepin also have strongly anticholinergic properties. Paroxetine is the main SSRI that has strongly anticholinergic antidepressant properties. So they should all really be avoided in older people. In my opinion, there are some people who clearly benefit from, say, low-dose amitriptyline for treatment of chronic pain or depression or insomnia, but there is a risk associated with that use. Paroxetine, I would suggest, should not be used in any older people. Short and intermediate acting benzodiazepines are in general best avoided in older people. And by that I mean alprazolam, lorazepam, temazepam, and oxazepam. There's pretty strong evidence that these lead to increased risk of delirium, falls, fractures, and motor vehicle crashes, and that the quality of that evidence is moderate. However, I should mention that long-acting benzodiazepines, such as diazepam and clonazepam, actually are very appropriate in several settings in older people. They're certainly appropriate for some seizure disorders, some people with REM sleep disorder, so people who have dream reenactment phenomenon often associated with Lewy body disease, people being treated for benzodiazepine withdrawal, alcohol withdrawal, and probably most relevance for the outpatient community setting, severe anxiety disorders. There are some older people for whom a long-acting benzodiazepine is the only thing that really makes them feel any better. But certainly temazepam, alprazolam, especially oxazepam, should be avoided. I'm really conscious that there are some older people that don't do very well without lorazepam or other short-acting benzodiazepines, and I think managing these people and managing expectations is really difficult. Antipsychotics in general should be used with great caution in older people, and that's because while they may have benefits, especially in people with psychotic behavioural symptoms associated with dementia, the risks are really quite considerable. There's a very real increased risk of falls, and I've looked after many people who've broken their hip within days of starting an antipsychotic medication. They also have extrapyramidal side effects, sedation, which is a big problem, anticholinergic side effects, and a small but real increased risk of stroke and death. And so when I prescribe these medications, I run through this list of side effects at the time of prescribing, and make sure that patients and their family are aware that there are considerable risks associated with use of antipsychotic medications. And that's really the reason for avoiding antipsychotics and until non-pharmacological options have failed, and there's a considerable threat to harm to themselves or others. I'm also conscious that management of BPSD, especially in nursing homes, is really difficult, and and antipsychotics often have to be used because there's no other option. I'll skip over alpha blockers fairly quickly. Prazosin should be avoided if at all possible, because it's highly associated with orthostatic hypotension. There are some people with post-traumatic stress disorder, for example, who have great benefit from prazosin, and they're probably the main group that I'd class as an exception. Drugs like clonidine and methyl-dopa, which are centrally acting alpha blockers, should also be avoided. I'll mention desmopressin not because it's commonly used, but because when it is used in older people, it's very commonly associated with big problems. So intranasal desmopressin is sometimes prescribed for nocturia due to idiopathic nocturnal polyuria, and there are high rates of hyponatremia associated with that. Hyponatremia can be severe with this medication and lead to falls and seizures and hospital admission. I think everybody's aware these days that there are concerns about long-term use of proton pump inhibitors. Strictly speaking, they should be avoided for use for more than a couple of months unless there are high-risk features, such as an ongoing requirement for oral steroids or non-steroidals, erosive esophagitis, Barrett's esophagus, or another demonstrated need for maintenance treatment. Weaning people off PPIs can be challenging, as there's this phenomenon of recurrence of symptoms when they're stopped. There is some, albeit weak, evidence of increased risk of a number of bad things in older people, including C. diff, bacterial pneumonia, chronic kidney disease, and fractures. Non-steroidals should be used with caution, at least in older people. They certainly shouldn't be used chronically unless other alternatives are not effective. But I certainly come across a reasonable number of older people who seem to use certain non-steroidals long-term without developing any of the complications we fear, such as peptic ulcers and GI hemorrhage or renal impairment. Sedating antihistamines are not uncommonly used for treatment of insomnia, and I think they're a bit problematic. Some of them have quite strong anticholinergic properties that aren't necessarily recognised by those who prescribe them. So doxylamine, diphenhydramine, and promethazine are the ones I see the most of. I used to use Phenergan after night shifts when I was a junior registrar, and it would completely knock me out. Sleeping is not the problem. I worry about what happens when people wake up, because it can have a persistent sedating effect as well as a more broadly anticholinergic effect. So when I talk to older people about insomnia, my general advice is that no sedating medication would be advisable, and that there'll be considerable risks of taking any sedating medication for treatment of insomnia. I think melatonin's okay to try. It works for some people and not others. Setting reasonable and pretty low expectations of what to expect with sleep, and to discuss exhaustively non-pharmacological management and sleep hygiene, I think, is the way to go. I'll come back to genitourinary anticholinergics, which I've touched on earlier. I think they deserve special mention because in my outpatient work, at least, they appear pretty commonly as avoidable contributors to delirium and cognitive impairment. The higher the dose of these medications, the greater the risk. So there are some older people who, even when they've had a frank discussion about the pros and cons of, say, oxybutynin, are so disabled by nocturia that they are quite happy to use oxybutynin, and that's fine. I think it's fairly common, though, that people start these medications without any idea of the cognitive side effects. And that's partly why people can be on a medication like oxybutynin for a year or more, by which time their cognitive impairment can be considerable before it's recognised that a drug could have caused this. The people who are most sensitive are people who end up being diagnosed with dementia with Lewy bodies. So I've probably got half a dozen patients that I've seen in the last year who have dementia with Lewy bodies, and that was really precipitated by oxybutynin use. And there weren't great clues before they started it that they were dementing. So I think if you are going to use something like oxybutynin, do it with great caution and keep an eye out on their cognition, because if things decline, then it may well be the cause. My preference would be that hardly anybody who's older should be on oxybutynin or solifenacin. I'll touch on statins because it's a bit of a cliche that geriatricians are meant to hate statins. That's not the case in general, and I hate so many other medications more that I don't have enough time for them. So there's actually good evidence that statins are very beneficial in older people with known coronary artery disease or other atherosclerotic disease, and they certainly reduce all-cause mortality and other nasty outcomes such as myocardial infarction and disabling stroke. There's also an association between statins and reduced mortality in people 80 and over with coronary artery disease demonstrated on angiography. I guess the point I would make is that they're likely of minimal meaningful benefit in older people with low life expectancy. So if for a variety of reasons, I think somebody who's older has a limited life expectancy, I would be quite happy deprescribing a statin. The picture's much less clear than in the secondary prevention space, and there's an ongoing Australian trial with results that were meant to be published this year, but probably won't be due to the COVID pandemic, that will hopefully answer that question. I'll very quickly mention cholinesterase inhibitors. The benefits in Alzheimer's disease are pretty limited. There are some people who seem to benefit, but many who don't. And gastrointestinal side effects are not uncommon. So that people need to be aware of that. If people on cholinesterase inhibitors develop those gastrointestinal side effects, I'd be pretty quick to deprescribe. I'm fast running out of time now, so I might just check whether any questions have popped up. I might not have enough time to touch on deprescribing, unfortunately.
Just to the left of question.
Okay, no questions so far, which is good because I can push on for a few more minutes. So there are clearly some medications which are potentially inappropriate or harmful in older people. That's fairly clear, but what's less clear is whether stopping them will make older people feel better or live longer. So this is a cautionary tale about a home visit by a geriatrics registrar who happened to be me, who went and saw a 76-year-old man who was happily living in the community with his wife. He likely had dementia with Lewy bodies, which is the reason I'd gone to see him, but he had another problem, which was 30 years of benzodiazepine dependence, which I very naively thought I could address after one home visit. And I made a recommendation to wean this man off oxazepam. Within a week, he was admitted to hospital with a delirium, which was clearly precipitated by benzodiazepine withdrawal. So the risks of deprescribing are not inconsiderable. So you can get discontinuation, rebound, or withdrawal syndromes when a range of medications are stopped or weaned. Antidepressants can be a problem. So paroxetine in particular, which I mentioned as a nasty SSRI for older people, is really hard to stop because it has a nasty discontinuation syndrome. Benzodiazepines are hard to stop, opioids are hard to stop, you can get withdrawal symptoms when high-dose L-DOPA is stopped too quickly. In practice, I rarely see cessation of beta blockers being a problem. We do it in hospital all the time, and it doesn't seem to cause much grief. Long-term corticosteroid use with resulting adrenal insufficiency that wasn't recognised can be a problem if corticosteroids are stopped too quickly. Clearly, deprescribing can lead to subsequent medical condition that was being, say, prevented by the deprescribed medication re-emerging. And the deprescriber will invariably be blamed for that unless there's been a frank discussion about that possibility beforehand. Pharmacokinetic and pharmacodynamic effects on remaining medications can emerge. For example, unstable INR for patients on warfarin when certain medications are stopped. And the one thing that I come across most commonly is this perception that deprescribing is giving up on somebody, or that it's a symptom of therapeutic nihilism. And what that means is that deprescribing often involves lots of talking, and communicating the rationale for deprescribing can be time consuming. I might stop there because I think we're running out of time. I
think you might have a couple of
So there's one question here, fish oil instead of aspirin, okay. I'm not quite sure what that question means. I'd say no. There's a short answer to that. Yeah.
Fish oil in high doses can thin blood a little, but not in an antiplatelet way.
Oh, we actually do have lots of questions. Sorry. Sorry about that, everybody. Okay. Is there a tool we can use to determine polypharmacy / inappropriate medications? So, few answers to that question. There is you can use Beer's criteria. There is a tool that calculates the total anticholinergic burden of medications. I think that's largely a research tool, and I wouldn't use it in clinical practice. So I think if you just have a list of medications with strongly anticholinergic properties in mind, you can't go too far wrong. Next question. Deprescribing PPIs is often difficult due to rebound, reflux. Any tips? No. I'm often not the one faced with the patient coming back with rebound reflux when I stop a PPI. So
do it slowly.
Do it slowly.
Very slowly as you need.
Yeah.
2 weeks on half the dose they're on, and then 2 weeks on second daily, and then give them PRN.
Long-term use of Panadol regular, how long will be safe? 1 to 2 years. I don't think there's any evidence of harm for long-term paracetamol use. I'd wonder why somebody needed paracetamol for longer than that.
You'd be making sure that it was working and that it was still needed, so trial a withdrawal to make sure it was still required, much like the PPIs, I suppose. And it's a simple enough thing to recommence if it's determined to be needed.
Yeah, completely agree with that approach.
Yeah.
All right, and that's it. So I might hand over to Catriona now.
Okay. Oh, so I need to move to the next slide. Okay, thank you for staying tuned. But I'll just get my talk up and we'll get started on dementia. Okay, oh, someone's going to do this for me, I'm certain. There we go. There we go. Should be ready to go?
Should be ready to go.
Okay.
Yeah.
Hands up. Yeah, we're good to go. Okay. So look, Yeah, this is an area I'm certainly very passionate about and makes up the most of my work, increasingly seeing younger patients, some of whom are very unfortunate and do have dementia, and increasingly people who are worried about it. And I think this is an interesting new group of people that are your patients out there, and you know, a lot of them are quite concerned about this. So what is new in dementia prevention? A lot of this is fairly low tech and obvious, and I think ties in beautifully with what you're all doing with your patients to help them avoid vascular disease and all sorts of other things. And I suppose the summary of all that is basically, if you live a healthy life, you'll get lots less of everything, which is at least neat. So dementia, oh, that didn't work. That's a shame. Hang on a tick, we'll just scroll down. Okay. So do I have to do it like this? Oh, no, I don't. Look, I don't. It's all good. So look, you already know dementia is very common. It's one of the most common things that happen as people get older. And with an aging population, obviously, that is huge numbers. And it's the second leading cause of death for men and the first for women. So this is a very common and serious issue. And compounding that, of course, it's incredibly expensive. The direct costs to healthcare, the indirect costs on all your patients who happen to be carers. You probably support a lot of people in that role. It has huge impacts on their health, and there are also intangible costs of dementia that come into that. So the other thing is that we have to note our attitude to dementia, and I think despite how far we've come with understanding dementia, we still, even as professionals, as you scroll down that slide, a lot of health professionals still feel it's pretty normal to get these things happening to you as you get older. And we will go through, you know, what is normal aging, but it is not normal to become demented, and many people live to a ripe old age without any cognitive issues of any note, and that should be our goal and our hope. There's also a lot of stigma attached to dementia. As for mental health issues and other things, we do take our brains terribly personally, and I think people are often very frightened about talking about this with their doctors, or they, you know, depending on the person, or they might be incredibly hyper anxious about it. So we get a whole range of spectrum of responses in the person and in the practitioner, and I think it's just worth thinking about that. One survey by, I think, Dementia Australia a while ago had, well, maybe it was them. Anyway, fear of dementia is meant to be one of the most, it was meant to be one of the most highly feared diagnoses. So I think if you compound stigma and fear and a sense that it might be normal anyway, we end up not really addressing this as proactively as we perhaps could. So yeah, as I say, it's normal, and it's not normal, and most people don't. So just to emphasise that, 1 in 4 people, 85 to 89, might have dementia, but that means the majority don't. So it's not normal, and we should respond when patients have concerns. The other very important factor is that modifiable factors collectively account for more cases of dementia than genetic factors. So it is something you can do something about. And in fact, one commission concluded that there were 35% of cases that could actually be prevented by addressing modifiable factors from midlife, across the lifespan really, but particularly relevant in midlife. So what is normal aging? As we get older, speed of processing can be an issue, and slowed processing is not always something to be too worried about. It's fairly subtle when it's in the normal range, and significant slowing of processing that's really noticeable and causing problems, of course, is not normal. Word finding difficulty, so just having a little bit slower finding of a word, or something out of context, for example, that can be fairly normal, particularly if it's words you don't use a great deal, or they're more complex words. Memory actually does change a little with age. Again, just getting a little bit slower. Our working memory, that part of our memory where we're right on the ball and we're working with information in our head and coming up with answers, that can become a little different. And just new learning, you know, interesting to think we often don't engage in new learning as much as we get older. We've been in our jobs for years and we're not perhaps doing new things with our brain, so that's got to be considered. But there is some reduction in that. We may not multitask as well, and we may not switch our attention within tasks as well. And yeah, so that's around fluid intelligence, how sharp we are, I suppose. But we do not normally get changes that are anything more than, you know, word finding difficulties with language. And we should be able to attend and focus on single tasks fairly normally. Our crystallized intelligence, of course, can actually go up and we become wiser, and our function should not actually change. So just to clarify a little bit of language around this, so if someone has concerns about their cognition, and when we do formal testing on them, there is nothing to see, and the history is not worrying, we call that diagnosis subjective cognitive concerns. This may in fact still be clinically relevant as we get better and better at detecting the early markers of changes, including the amyloid scans that are now becoming available. It is quite probable that people with these concerns may in fact be, you know, yes, preclinical. But of course, having said that, there are many, many reasons why you might not be feeling as sharp, and we'll go through that later. So mild cognitive impairment is a formal diagnosis, and it's based on a measurable change in your cognition on testing. It does not have any effect on your day-to-day function. Dementia, of course, does affect function and will change over time. Dementia can be diagnosed nowadays in the presence of just one domain of cognition being affected. It used to require more than one. Rates of progression of mild cognitive impairment over, you know, 5 or more years. Yes, it's a serious finding. Mild cognitive impairment comes with a serious risk of progression to dementia. It is not inevitable, but yes, it's fairly significant. And particularly if we get what we call amnestic MCI, where patients have the rapid forgetting style of memory loss, where they might encode information quite well, but then, you know, it's just gone and you can't even prompt as well as in other forms. So vascular dementia, for example, they tend to have more trouble encoding, but with, you know, they'll recall it better after a delay actually. So yeah, noting that other forms of dementia, of course, it's all not just about Alzheimer's. Of course, Lewy body's been mentioned already tonight. That's quite common, up there with vascular really, and an important diagnosis. But yes, as the final point says, a lot of people don't progress and they can improve back to normal. So that's what we want to try and guide our patients to. I think I can probably skip over this. We've mentioned that. And I'll probably skip over that too. So I've just mentioned the amyloid scans. So these are available. I'm not going to have one. I think it sounds like an awful idea. And I have not yet actually ordered one. I've certainly seen a few patients who have had one, and it takes quite a lot of work to support them through that positive result, particularly when they're being done on people with normal cognition, which is starting to happen occasionally. So the negative and positive scan are labelled there. It's basically red is bad. That's actually amyloid being picked up there on the tracer. And it's known that this can predate dementia by many years. Of course, the problem clinically is we don't know in the individual who has the scan positive how long that will be. So update, yeah, future diagnostic tests. So beyond MRI, really, other tests are not being widely used outside of research, although, yeah, there are some available. There are not just, in fact, amyloid scans. We can also do scans on the other abnormal finding in Alzheimer's dementia, which is the tau, and some other dementias. And we also do use FTG PETs occasionally to look for you know, different metabolism in the brain, which can be indicative of problems. And there are some scans, certainly not widely available at all, that can pick up some abnormalities consistent with Lewy body. But I think what all of this says is we're getting to a point where we may be able to refine diagnosis a little more based on, or with support from testing. And this is all still in the research stages, so I don't think that it's wise to jump ahead too quickly with this. It's certainly been my clinical experience that the people that have had these scans done are quite devastated. And we don't actually know what it means. So it takes a lot of communication and explanation to sort of guide them through that. Retinal amyloid scans are starting to become done, and that obviously might be simpler and a bit cheaper. That's again still research. We can do testing of CSF for amyloid and tau, and that is certainly available and not that expensive. And that might be useful in a person for whom, you know, they want more information about whether this is really consistent with Alzheimer's or whether there's something else going on. Over time, and still certainly in the research realm, biomarkers that indicate a little bit more about why that person in front of you has dementia or has risk of dementia might be very useful clinically. If, you know, in any given person, there might be any number of factors that are relevant for why they have it. So inflammation is a huge factor. And in fact, most of the genes that are known to be linked with dementia actually code for inflammatory processes. So it's probably quite important. And obviously vascular disease and metabolic factors we know are very important. And then there's the neurodegenerative markers that we've touched on, which might be picked up in blood, which would be lovely, much easier, CSF, or even breath. There are some breath markers being looked at. You may be aware of the ApoE gene, which is a risk gene, and it's actually, yeah, it's quite a, you know, as risk genes go, it's a pretty serious one. I don't routinely test it. It's not usually that clinically useful really, but it just confers a higher risk of dementia. Okay, so current understanding on etiology of dementia, as I just referred to, there's certainly a number of factors involved in this condition, and that's probably not surprising. It's in many ways, you know, it's coming on for many years before it's clinically apparent. So it's kind of a silent process going on in the background there, and there are many factors that are all intermingled, many of which might be happening in the one person. So yes, there are abnormal proteins deposited, amyloid, tau, synuclein, TDP43. We've got inflammatory processes, we've got oxidative stress, we've got atrophy where the synapses are failing to function and the neurons are dying, so just simple dropout. Excitotoxicity is an interesting one. Other toxicities may be relevant, vascular factors, and then the mitochondrial and the metabolic factors. And each and every one of these is actually really fascinating and potentially very important. And there are big groups everywhere around the world working on these separate things and coming together for what I find very interesting meetings. So yeah, current drug treatment, nothing to say here. There's been nothing new or exciting in just so long. And as Phil's referred to, the acetylcholinesterase inhibitors are not that exciting. We do occasionally, I'd certainly get some people for whom they do bring a useful benefit. No one's ever wildly excited, but you know, I'm often, well, if they don't help, then you should be weaning and ceasing them. And that's another opportunity, of course, to decide whether it was doing anything. And of course, if things deteriorate, you can certainly restart. And memantine as well. Some people use both. I like to do one first, usually the first group, and then once we've decided whether that's adding anything and they're keen, you might add memantine. Of course, they can't get both on the PBS, but they're relatively cheap drugs now, and they can be used together if there is an additional benefit of the second drug. And I think this is the thing you have to do. These drugs could potentially be in use for a very long time, And so it's important to establish whether they do anything, and if they don't, there's no point at all continuing them. They are not disease-altering drugs at all. So review after 12 months, some more recent information seems to suggest might be reasonable anyway. We used to just leave people on them forever. And I just really go on the individual and what they want and what seems to have helped. There certainly are some people that do seem to get a benefit. Suvanade, you may or may not be aware of, is a nutritional supplement. It's milk-based. It's got very low doses of vitamins and minerals. It's not comprehensive in that way. It's got fish oils in a reasonable dose, and it's got a very big dose of something called phospholipids, which is very important in the health of the synapse, which is where it all happens. So this is a supplement that costs about $3.80 a day. It is always best obtained directly from Nutricia that makes it, because the chemists sometimes charge nearly double that, and it is meant to be taken every day in the long term. It's been trialled with Aricept. It's got small benefits, and there was some data that came out last year in an MCI group where daily use over 3 years was starting to show, you know, a modest reduction in moving on to dementia. So it may be protective. I basically say if it's palatable and it's affordable, why not? It's not going to hurt. Is there disease-modifying treatment on the horizon? So look, as I said, it's a complex issue. There are a number of big drug companies pulling out of dementia research because it's expensive and just negative trial after negative trial. The long preclinical phase is a big issue, and the idea that you would be potentially using drugs in people way before they've got clinical disease is obviously complex. And I think, again, it's a possibly quite heterogeneous disease in a number of ways. What happens in the lead up to the plaques and the atrophy and the functional changes is possibly different in different people. But certainly our understanding of it is expanding, and potential interventions are obviously very numerous when you look at the number of causative factors. And it's increasingly obvious to researchers that multiple factors will probably need addressing simultaneously. Yeah, wow. So everything's being looked at. There's nothing really that isn't being looked at that much. So yeah, we're looking at amyloid. The amyloid trials trying to remove amyloid from the brain are just generally not working. There are some still plugging away, trying to refine dose and pick their patients differently. And there are some of those still running in Sydney, but not looking positive. There are some tau trials. There are some interesting ways to address neuroinflammation, vascular health, ultrasound to break down the brain barrier and get things in there. The microbiome is being looked at, as it is for so many things, and that's an interesting area. I think supporting mitochondria and the metabolism of the neurons interesting. And also longevity research that's just looking at the longevity of cells and people in general is potentially going to have a lot to contribute to this outcome as well. And sleep and lifestyle is certainly a big interest at my work place in Sydney. And you know, we know a lot about how sleep apnea and poor sleep is a problem in memory. We sort of all know it ourselves from our own experience, but it actually in the long term, healthy sleep is very important for brain health. It's when amyloid plaques get removed and memory gets consolidated, and it's important for energy to exercise. It just feeds into everything. So I think it's really important to spend that time working on healthy sleep with your patients for so many outcomes. So the biggest multimodal prevention trial is the worldwide FINGERS trial, and that's been, you know, coming out in many iterations around about, and the ARROW trial I'm going to start working with later in this year is one such trial where they managed to demonstrate that with a number of interventions across healthy lifestyle, nothing that complex, you know, eat well, exercise well, sleep well, all of those things, brain training usually included. They had better processing speed, executive function and memory, which is a fantastic outcome. We can't get drugs doing this. and less comorbidity, and interestingly, less time in hospital, because funnily enough, the same exercises and lifestyle will support health in general. So importantly, if we can delay diagnosis by 5 years, we can have a huge impact economically and in every way. And as I've mentioned, it just ties in with good health for all sorts of outcomes. And there's been a lot of attention on this lately. Most of the suggestions for dementia risk reduction actually carry over to how we manage at least early dementia as well. So this was one such document, policy type document, where we're really just basically trying to say, look, when you improve your body health, you're going to improve your brain health. So it's really what you're already doing. And yet I think because people are afraid of dementia, it might well add weight to your encouragement of your patients to exercise and sleep well and look after themselves. It might motivate them more than other things, and that's very individual, but it's worth including this as a reason to make changes. There's some WHO guidelines. A lot of this is all very recent, and I think this is just a graph that's outlining if we can delay things by no years at all, if we can make no impact, by 2050, we're going to have the 3 million cases. Well, this is just numbers. So 3 million cases. And then if we drop that down to, this is probably not Australian, so don't worry too much about these figures. They look totally too terrifying. But if we can actually reduce the rate of dementia or slow it down by 5 years, you can just see that the impact on the actual numbers is massive. This is actually an outline of the recommendations. This one might be a good one to come back to and just sort of look over. It just goes through the very thorough reviews very recently done on what does actually reduce risk. And you can just see how that all just ties in with good medical care in your practices every day. So I just think this adds extra weight. So yes, we're not meant to smoke. We should be physically active. The recommendations are 150 minutes, moderate intensity exercise, include weight and aerobic. So resistance training is particularly important, I think. And for all my patients, particularly my older patients, it's just so essential in terms of avoiding falls risk reduction and frailty. Muscle is just so important as you get older. And it's not always the first thing that the older population thinks of when they think of exercise. So specifically saying that is something I always do. And, you know, I think it's partly culturally we all, you know, I grew up on, I'm not speaking about Phil here, he's too young, but you know, we all grew up on norm and aerobic exercise, and, you know, really strength training has a lot of evidence and should be included. So yeah, diet. The diet that's recommended is actually a combination of the DASH diet for hypertension and the Mediterranean diet, and it gets called the MIND diet. But it's basically a very healthy Mediterranean style diet with low sugar. So alcohol, yep, I certainly think if people are showing signs of cognitive impairment, I suggest they give it a try if they're open to it, of actually stopping that. I'm not talking about high consumption, that would be done more carefully, but it's always worth seeing what it does for just general well-being in the individual, and it's surprising how many people find they sleep better, feel better, do more, think better. So it's always worth a try. So yeah, social engagement, keeping your brain active, learning new things. The brain loves novelty. And learning, and doing it in different areas to what you might have done before can be particularly useful. Sleep we've touched on. Referring, I know that there's not a great referral network of sleep studies and people up here, but you know, getting that looked at and considering that is very important. Certainly had many people for whom the treatment of sleep apnea that may or may not have been obviously present, you find it and they treat it and they actually feel a lot better in their thinking as well. So yeah, cholesterol, we've touched on the statins. They seem to be safe in terms of, you know, the risk of statins and causing a problem. We've pretty much definitively shown that that is not the case. Obviously, if there was a person who seemed to get cognitively impaired immediately after starting one, you might stop it and see what happens. But I've actually not seen anyone convincingly has had that. I agree with Phil's earlier comments there. But it's not really shown that statins, lower your risk significantly, or, are going to change anything, particularly once you've got dementia. That's not a reason to be on a statin. Hypertension, really important to manage for all sorts of reasons. Atrial fibrillation, we know about. Stroke. Depression, interestingly, increases risk of dementia. It's worth knowing that. A lot of the lifestyle interventions we're talking about will also lower depressive symptoms, and non-pharmacological management there, particularly avoiding the anticholinergics, is important. So yeah, benzos, they do increase the risk of dementia. They prescribe where possible. Yeah, the anti-inflammatories, so NSAIDs may reduce risk, but we don't prescribe them for that purpose. So I don't prescribe non-steroidals to lower risk of dementia in people who are worried. The evidence wasn't suggesting that one would do that. But if they need it for other reasons, that might be another thing. HRT is a very complex area, doesn't seem to reduce risk. And anticholinergics we've talked about, and we'll move on. Obviously, head injuries should be avoided. So just, yeah, wearing helmets, being careful. Dental health, really important as well. There's, bugs from the mouth found in amyloid plaques and periodontitis and inflammation, and it goes from there. Important for all sorts of reasons. Vascular health as well. So yeah, we're talking about blood pressure here. Look, we're going to be treating that anyway, so I think we're going to not dwell on this too long if we're running out of time. And just being careful, of course, in dementia and older patients. Any hypertensive, there's not one that's better than the other for this. And there's other aspects of cerebrovascular health that are being looked at in studies that might become relevant over time. Diabetes and insulin resistance. You're probably familiar with the idea that we are careful with targets in our older population if they have comorbidities, particularly frailty. We don't want to be pushing the targets too low, and we want to avoid hypoglycemia, of course, but in the younger populations, of course, this is something to look after. Well, exercise we've talked about, and I just wanted to emphasise that important role that you guys have in, you see the patients regularly, and just mentioning these things that are, I think patients do respond to having these things mentioned, and just helping them really see how relevant it is as they go on their path of behaviour change and motivation. So we do have that role. Building slowly, but building is important. So I think particularly in the older people, be careful we don't sort of go too gentle on them. It is important that the actual required amounts are met before you start to get the physiological changes and the neurotrophins being released. So if we really want these things to work, we have to do what the evidence suggests we do, much like we would with any drug. The dose and the frequency, if they're not the right dose and frequency that were shown to work, well, the intervention may not work. And I think that's a really important point to make with exercise with your patients, because it is so powerful and there is just so much evidence for it across so many outcomes, and it has benefits across other conditions. And actually, some trials have shown that adherence to exercise can be fantastic. So I think we often just fail to, or we underestimate potentially our patients' ability to do what we suggest. So that's good. Making these things clinical priorities, I think, are really important. I don't think there's probably enough on stress. When I go to conferences and things, I think people probably don't talk about it enough, because cortisol can shrink the hippocampus and causes all sorts of problems, contributing to depression, interfering with sleep. So directly and indirectly, I think it's a big one. And I suppose see a lot of carer stress as well, that we need to think about our carers in this context too. Managing adverse life events, depression, anxiety and burnout. I've talked about diet, and I think just considering diet as a dietary pattern rather than a specific, so a way of eating, which I think the mind diet really is, and just remembering the social aspects of food as well that are really important. Okay, so I just think in the last few minutes, I just want to encourage you to sort of really proactively inquire and respond to patients who are concerned about their cognition, to not think it's normal. You know, that's what I'm here for, and Phil's here for. We are happy to see these people and help work out what's going on for them. Some people are unlucky enough to have early onset dementia, as I've mentioned. And certainly I can't count the number of people that have gone away totally relieved that they're, you know, forgetting their keys twice did not mean that was it. And some people are literally that anxious. They may not tell you that, but when you dive in, there is a lot of anxiety around this sometimes, and sometimes they're living with that for many, many years. So yeah, I think the screening tests, you know about, the basic bloods and tests are there. And yep, decide on a referral. And again, just discussing risk reduction in line with other preventative work. I think we'll pop over, I think we'll pop over that in the interest of time. Yep, 2 minutes, yeah. We've talked a little bit about dementia management, of course, the legal and other planning, the driving, that's, you know, obviously we're here for that. That's a difficult one. It takes a lot of time sometimes for some people, and we can help with that. Reviewing other conditions around the context of dementia changes our priorities a little, particularly as it advances. Okay. And yeah, look, we probably haven't had time to really get into dementia, but I just think on a practical note, I wanted to make this comment that, you know, it's very different for every single person, because for some people, they have such an amazing support around them that it almost doesn't matter. You know, all their needs are met. Everyone just gets on and shares it, and it's fine. And then we have people who it is a very early problem and no one's coping, and it's just an overwhelming situation. So finding out where your patients are at and helping them find, well, what's the things that would make the most difference to your life. And that may be a change in who's doing the caring. It might be getting support into the home. That can be totally life-changing, to take that burden or share that burden for the carers. Things like that can be amazing, but it's going to be different for everyone. So it's a case of just that history and connection with your patients that you know so well. Okay, so time is up. Yeah, okay. Can I just say very quickly this one? I just wanted to say that, yeah, patients want diagnosis, generally speaking, not everyone, but most people do. There's often a big delay in diagnosis, so we've often missed opportunities to make early changes. Planning is important, and it's obviously easiest done early. And that might be stuff like bucket list stuff for the person. It might be planning for the family. So the earlier, the better. And medico-legal issues, it's interesting that, you know, 1 in 5 cases can be due to failure to diagnose something. And I wonder, as things shift with our understanding of dementia, where that's going to be something that people increasingly get annoyed about, that it was a delayed 3 to 7 year delay in diagnosis. So we don't mind one bit diagnosing mild cognitive impairment or reassuring people. I love doing that. So send them along. And here's our referral pathways. And I'm really happy if you want to ring me or get in touch if you're not sure about something, just feel free to do so. If you've got patients that want to come through a fabulous sort of bulk build research clinic with free scans and sleep studies and the works, well, they get neuropsych done as well. You can send them to me there if they want to stay the night over there and do the full bit. Otherwise, get in touch. Thank you. Questions, I think we're just going to have a look. Okay. Hi, Jackie. I need to read your full question. Hang on, I can only see.
Click on it. Click on it. Yeah.
No, that's Phil's question. Okay. I think some of my colleagues are having a joke with me. I can't read all of them. They don't have the full question there. How often should we be doing a mini mental? Thank you for that question. Yeah, we're not really meant to do them that frequently, like 6 to 12 months tops, for any cognitive test really, because there is a bit of a practice effect. Look, naturally, once someone's got more advanced dementia, that doesn't matter so much, because they just look at you like they've never seen it before. So that's a little bit variable. When should a patient be referred to a geriatrician? Okay, there's so many reasons to refer to a geriatrician, Phil. Feel free to time to sort of chirp in there. Certainly, yes. People who have got complex and multiple comorbidities and are starting to get those geriatric syndromes, such as cognition, falls, frailty, polypharmacy, potentially you've got multiple specialists who are all kind of just adding to that list, and you want someone to sort of look at the whole patient as one person, I suppose. That would be the main reason. Yeah. Long-term alcohol drinking, yeah, not a good idea. So I suppose the NH and MRC guidelines are that we shouldn't have, I should know them off by heart, 2 drinks tops on a regular basis with no more than 4 ever really. That's considered a binge. Standard drinks, of course, and ideally it's less. Yeah.
I've had some real success stories with people with alcohol-related cognitive impairment that were really, really impaired when I met them and became almost
normal again. Yeah, it's fantastic.
Abstinence. Of course, there are some other people who did shockingly badly.
Yeah, yeah.
But some of the people who do the best, who come through geriatric medicine clinic with concerns about the cognition are drinkers who can stop.
Yep, it's great. And don't underestimate. People do. It's interesting. You get people that go, oh, no, I'd never give it up. And then you just stay with it and you just say, oh, have you thought about that more? Because it's worth thinking about. And I suppose when you think about it, it's just affecting, it drains nutrition, it affects sleep, it could cause sleep apnea or worsen it, it lowers mental health. It can, so there's multiple mechanisms, but sorry, not a good idea. Vitamins might be helpful if you're deficient. B12, folate, B6 are the ones sort of more looked at. B1's relevant to alcohol and thiamine deficiency, or a very high sugary intake potentially can do it too. Turmeric can, so turmeric's a funny compound. So it misbehaves in trials. It's sneaky somehow and is hard to, there's something about it that makes it hard to, I work with an expert in this and he explained it once. It's but look, you do get people that find it helps their joints, and it can theoretically help your, so you might exercise more, and it can theoretically help the release of neurotrophic factors in the brain. So look, it's probably safe unless you go crazy. So meditation, I'm a big fan actually. I think because there's that mental health and stress stuff and sleep stuff that I do actually recommend it to heaps of my patients, the majority I would say, because for most people there are issues and things to be gained, and done well and in the long term, yes, it can improve connectivity in the brain. Could you please comment on the Propsol, that another name for dementia is type 3 diabetes. Okay, so yeah, look, I've heard that type 3 diabetes concept. So metabolic mitochondrial health is important. Diabetes it doubles your risk of dementia. So it's basically about insulin resistance in the brain. So the brain requires glucose. It can also run on ketones, and there's your low carb diet and your ketogenic diets and things for that. It's an alternate fuel, so if it can't get the glucose in, that's your insulin resistance. So I think that's where all of that's happening. But mitochondria are very important in all sorts of health conditions, and definitely dementia's one, but it's not one thing, definitely, it's multiple things. Okay, you've clicked on, what's this? Comment on the value of an MRI. Oh yeah, so these neuroquants, so measuring the hippocampal volume. We don't do that in our research clinic in Sydney, but it can be done. We're not diagnosing dementia based on, it's not like there's a cutoff and we say, well, you've got Alzheimer's, because that's not how we do it. It's like one part of the information that we put together clinically. So yeah, it's an interesting thing, because I suppose some people are using it, not many, but some are using it to show over time that the hippocampus isn't shrinking as much as it was, and you sort of get a sense you're winning. But I kind of think clinically that's what you want to go on, because the whole aim of it is to function better in real life. So I must say I stay largely clinical. I don't repeat scans a great deal actually, unless there's a good reason. Once diagnosed regarding driving skills, how often for driving? So look, we, as you may be aware, legally obliged to, the patient is legally obliged in New South Wales to tell the RMS that they've got dementia, and then the question will be raised with the doctor as to whether or not they're safe to drive. Some people can drive for years with dementia. Short-term memory itself isn't so much of a problem, but slowed processing, visuospatial skills, all sorts of other things might be. So it's really about coming back to the individual. Don't hesitate to refer people like that. I think annual review for such a serious condition as dementia, 6 to 12 monthly review, helping families, looking at things like driving safety is quite reasonable. But they legally have to be, once they've been listed as having a dementia, they have to be medically reviewed every 12 months. That's a condition on their licence. Phil?
Yeah, I'm probably on the meaner side of the spectrum for driving. Dementia. Yeah. So, I certainly,
pretty
my
mean.
policy is I try and make a decision. Either they have an OT driving test or I write a letter to the RMS recommending cancellation. I wouldn't have, but I have some patients who I would let drive if I had a reassuring OT. So I'm very conscious that I'm on the meaner end.
That's mean. Yeah, it feels mean. Okay. So yeah, and there's a variation amongst practitioners. I definitely don't think I'm soft, but there are people who, I think if you've referred them for an OT driving test, that means you think they can drive and you just want to make sure, I think. Yeah. I mean, you wouldn't refer them if you'd already decided they couldn't, because you wouldn't waste their money. But you sometimes do the RMS test. The RMS test is incredibly easy to pass, and so it's not a good clinical thing. I would do it just in cases where they probably are great, but we just want to get an objective someone to say, okay. And in early stages, if it's really just their short-term memory and their processing speed and attention and focus are sharp and their visuospatial skills are good, then that's okay. So I'm kinder than Phil, I'm pretty sure, but maybe not super kind. Okay, if you have MS, you need to have a yearly exam. Is that a question? I'm not sure. I'm not sure. I don't personally manage MS.
I think that's just next to the driving test.
Oh, okay. Yeah. But they don't have to have an on-road with dementia. They don't have to have an on-road RMS driving test. No, they just have to have the doctor say they're okay.
It's a pharmacy-related question here for Dr. Butler.
So another question regarding pharmacy. When should and how often do we refer for pharmacy
medicine review?
Yeah. I think I've found over time that use of medications that doesn't bear much resemblance to what we have prescribed or what we think should be going on at home is pretty common. So I'd probably underuse pharmacy reviews.
Yeah, I think I do too, but they are a good idea. I love the idea.
Especially getting an accurate idea of how people are actually using medications at home is really important. And it links in with polypharmacy in complicated ways. Many of the medications that are unsafe, supposedly in older people, like antidepressants, are particularly unsafe when people are stuffing up their usage and accidentally taking them 2 times on one day and skipping a few days.
Yeah, absolutely. I think, look, medications and driving and occasionally some other safety issues, I usually spend a fair bit of time talking about those in dementia too. It's like there are certain things we don't want to take risks with. We want you to be independent and do lots of things, but you know, safety stuff like driving and medications, we need to go a bit overboard on safety.
That one could be there, Dr.
Oh, the tool. We did talk about that. Okay. Yeah. Okay. I think we've got that.
I think it's like all the questions have been covered. Yep. Wonderful. Well, look, thank you so much, everyone, for dialing in. There's obviously a lot of information to cover in both of those topics, and we realise we've sped you through tonight. So thank you so much to Dr. Butler and Dr. Ireland for giving us their time tonight. On the survey that will come up when we end the webinar, we do ask about future learnings. So please detail anything else you want covered We realise there are lots of webinars at the moment, so you know, we will be prioritising what comes through. But yeah, please list everything you want us to address, and we'll certainly do our best moving forward with our webinar program. But we'll let you get back to your evening, and thank you all so much. We'll talk to you again soon.
Thanks.